Good afternoon, distinguished ladies and gentlemen. Welcome to today's webinar organized by the Center for Communication and Social Impact. Thank you very much for joining this webinar today. My name is Precious Omonuju and I'm moderating this session. I also want to welcome our 5 distinguished panelists who will be introduced shortly. So CCSI is an organization, an NGO that focuses on the central role of communication to impact, build brands, and also lead technical guidance for behavior change. At CCSI, we actually do quite a number of things. We're involved with capacity building, entertainment, education. We're known for behavior change communication, brand development and promotion. Also very good at multimedia documentation and quite a lot of other things as an organization. But for us at CCSI, we have 2 flagship programs, one of which is our entertainment education Newman Street TV series, where we use the entertainment education to actually change behavior. Our second flagship program as an organization is our capacity building program, which is the Leadership in Strategic Communication workshop, which occurs annually. And this annual workshop has been a cornerstone in CCSI's capacity building mission. In commemoration of World Population Day, today's webinar is focused on influencing sexual and reproductive health behavior in the COVID-19 pandemic, in line with the theme of World Population Day 2020, which is putting the brakes on COVID-19, how to safeguard the health and rights of women and girls. I'm sure we're all in for a good time this afternoon because this is going to be a very interactive webinar. And our distinguished panelists will now be introduced. And as I make their introductions, I would like each of them to put on their video during their introduction. So we'll start with Dr. Afolabi. Dr. Kayode Afolabi is the Director and Health, Reproductive Health Division, Department of Family Health, Federal Ministry of Health. He has several years of experience in the field of reproductive, maternal, newborn, and child and adolescent health in Nigeria. He also served the Oyo State Government of Nigeria as an Honorable Commissioner of Health, and he currently provides leadership in sexual and reproductive health system strengthening, government policy development and implementation, and the development and humanitarian program management in the RMNCH towards improving the health of the mother, adolescents, and the under 5 children in Nigeria. You're very welcome, Dr. Afolabi. Thank you for joining us this afternoon. Our next panelist is Dr. Seratu Olabode Ojo. Dr. Seratu Olabode Ojo is the Technical Director of Programs, Johns Hopkins Center for Communication Programs, the Nigerian Urban Reproductive Health Initiative 2 project. She is a public health practitioner with several years of fieldwork experience at the national, state, and the local government levels. She has a high level of expertise in developing and implementing health programs in both the private and the public health sectors. Her areas of expertise include primary health care, sexual and reproductive health, family planning, MNCH, PMCT, ART, and gender programs. She has a track record of executing result-oriented developmental health projects and optimizing healthcare delivery. You're welcome this afternoon, Dr. Seratu. Thank you very much for joining us. Our next presenter and panelist is Margaret Bolaji. Margaret Bolaji is an international development professional with particular interest in adolescent and youth sexual and reproductive health. She is the founder of Stand With a Girl, the SWAG initiative, dedicated to ensuring that every girl in Nigeria is empowered to fulfill her maximum potentials. She recently worked as a youth program advisor with the Johns Hopkins Center for Communication Programs, the family planning portfolio in Nigeria, and has worked with Population and Reproductive Health Initiative in the northern Nigeria, where she empowered over 10,000 marginalized adolescent girls with sexual health and reproductive health rights, literacy, and life skills. Margaret is a 120 under 40 winner, the new generation of family planning leaders. You're welcome, Margaret. Thank you very much for joining the webinar this afternoon. Our next panelist is Dr. Shitu. Dr. Shitu Abdul Aguye is the Deputy Project Director on USAID's Breakthrough Action Project in Nigeria. He's a public health physician with several years of clinical and health development program implementation experience. He currently leads on integrated social behavior change and family planning interventions. He has played key roles on implementation of several maternal, newborn, and child health programs in multiple states across Nigeria, providing technical and programmatic leadership on the RHFP and MNCH intervention projects. You're welcome, Dr. Shitu. Thank you for joining us this afternoon. Our next panelist is Adenike Ayodele. She is a program officer at the Center for Communication and Social Impact, providing support to projects implementing strategic behavior change interventions. She has extensive experience in family planning programming, having worked on the first and second phase of the NURI 2 projects. She also supports interventions in other thematic areas across health and social development at CCSI. You're very welcome, dear panelists, and we are ready to dive into today's webinar. Dr. Afolabi, how has the COVID-19 pandemic impacted family planning activities from the perspective of the Federal Ministry of Health? I'm handing the floor over to Dr. Afolabi, who will take us through this afternoon.
Since we recorded the first case of coronavirus infection on February 28 this year, we're having a very spike increase in incidence of this infection. And now we have over 30,000 cases. Lots of disruptions has occurred, virtually in all sectors, and of course, also in the way we live. We look at the global level impact. The fragility of our supply chain has actually been exposed, and this has led to delay in commodity availability, and a projection has been made that over 47 million women may lose access to modern contraception, and over 7 million unintended pregnancies with sequelae of this unintended pregnancy may occur if the impact of the pandemic persists for up to 6 months. There is heightened risk of stock out affecting commodities, including implants, injectable pills, condom, as well as some intrauterine devices. And of course, this stock out will be more felt in certain countries, including Nigeria. Next slide, please. So if we come to the country level impact, initially the coordination and leadership role of Federal Ministry of Health was badly affected due to the lockdown in 3 states, Lagos, Ogun, and FCT, which later extended to other states, as well as restriction in meetings and gathering. Also, there were no protocol for service delivery during an outbreak like COVID-19 pandemic. And to make it worse, reproductive and family health were not initially prioritized in the COVID-19 response. Further impact include the fact that there were delay in clearing commodity from ports, and this affected our first scheduled national family planning commodity supply to states and FCT. And at the service delivery point level, there were initially non-availability of personal protective equipment And of course, this poses a lot of risk of infection to health workers as well as even our clients. And the overall effect of this was very sharp decline in family planning uptake. Next slide, please. So this sharp decline in uptake of family planning commodity is brought out more by this graph from the National Family Planning Dashboard, where we realize that three commonly used commodities witnessed a lot of decline. For instance, injectable uptake was reduced by 29%, while implant uptake was reduced by 20%, and intrauterine contraceptive device was reduced by as high as 14%. I have the next slide. So we did not just fold our arms and say all the fears, the uncertainty that COVID-19 pandemic has come, we just stay and we will not do anything to mitigate this impact. So we went into action to address the impact of COVID-19. The first thing that we did was to secure approval from the Honorable Minister of Health that reproductive health and family planning services and information should also be prioritized in the response of COVID-19 pandemic. And we got this approval. Honorable Minister himself, Dr. Sage Hanire, communicated with all the honorable commissioners in the states that they have to ensure that family planning information and services are prioritized among the interventions that will be taking place during COVID-19 response. This brought a lot of respite, and we also went further to ensure that we have an action plan generally covering reproductive, maternal, newborn, child, and adolescent health services. This has been further expanded. Innovatively, we're able to conduct supply of contraceptive commodity to all states and FCT. And we are currently expanding contraceptive choices by scaling up and introducing hormonal intrauterine device. We also communicated to states, and we are providing support for them to ensure that they keep the maternity units in isolation center for delivery of pregnant women who have coronavirus infection. Your state has had a delivery of a woman, and the outcome was quite very successful. Also, we've been having several coordination and leadership meetings with both in-country and global partners. This was initially disrupted, but we were able to leverage on technology. So let me quickly conclude by saying that we have been quite innovative in responding to the impact of coronavirus infection. And our innovation saw that we were able to supply commodity to states and also support states to conduct last mile delivery so that family planning commodity will be available at service delivery points. We adopted online and web-based training approaches to ensure that we sustain capacity building. And currently we are strengthening community-based family planning program so that women will have access to FP commodity and services in their community. Very importantly, we have succeeded in integrating family planning services into the overall national response to COVID-19 pandemic. We are developing a national guideline for self-care, which we find very useful to ensure that services are not further interrupted by impact of COVID-19 pandemic. Finally, I'm very happy to announce to everyone that the federal government of Nigeria, through the Federal Ministry of Health, continue to prioritize funding of family planning. And this has made the Honorable Minister of Health, Dr. Sage Hanire, to have the Appropriation of 2020, Appropriation Act of 2020, containing 1.22 billion naira, which had been earlier allocated for family planning before the revision of the Act. I thank you very much once again.
Dr. Saratu Olabode Ojo, prior to COVID-19 pandemic, what did the sexual and reproductive health look like? And what is the future of sexual and reproductive health in the light of the COVID pandemic? Over to you, Dr. Saratu.
The Nigerian Urban Reproductive Health Initiative is funded by Bill and Melinda Gates Foundation and led by the Johns Hopkins Center for Communications Program. The first phase of the project was from 2009 to 2014, and the second phase ran from 2015 to end this year in 2020. The vision of NORI is to eliminate supply and demand barriers to contraceptive use and to make family planning a social norm in Nigeria. We currently work in 3 project states, Kaduna, Lagos, and Oyo, and we also support the family planning effort at the national level. NORI uses a demand-led and theory-driven data programming. Please, can I have the previous slide? To support family planning programming using a 3-pronged approach of advocacy, demand generation, and service delivery, with adolescent and youth health programming integrated across these 3 thematic areas. In advocacy, we work to support, to create a supporting environment for family planning programming within the country through improving family planning dialogue and discussions, improving funding for family planning, improving the policy framework for family planning, and then using the media to improve family planning messaging and advocacy to support family planning efforts in the country. We also work using demand generation approaches to improve community demand for family planning using multimedia messaging, campaign approaches, and entertainment education that uses targeted messaging to address the needs of the population depending on their reproductive health needs. We also use a social mobilization intervention that sees community efforts and household interactions for family planning so that they are linked to facilities where they need the services. In service delivery, we work to improve equitable access to quality family planning services by integrating family planning across the continuum of care and also at the community level so that those who need services are able to get those services. We also work to expand and to improve the family planning commodities that are available so that people have a wide variety of choice. And then using the 72-hour makeover approach, we work to improve the in-clinic quality of services by revamping and renovating health facilities such that they're able to provide quality services, and health providers are able to be trained and provided with the tools that they need to provide quality services. So in all our work that we do, we work at multiple levels. We work with different stakeholders. We work at the facility level and we work at the community level. We've also, with the stakeholders, we work with government at all levels, from the Ministry of Health, the Primary Healthcare Development Agency, the Ministry of Information, the National Orientation Agency, the local government, civil society groups like the advocacy core groups that work to change social norms at the community level, even the interfaith groups that support family planning efforts right at the community level, with the media and other implementing partners. At the facility level, we work with the health service providers, with the clients. We support family planning commodity available, on the job training, coaching and mentoring of service providers. We give technical assistance to ensure operational effectiveness in health service delivery. At the community level, we work with the gatekeepers, the youth influencers, the men's group, the women's group, and at the household level, just as I mentioned earlier, through the social mobilization efforts. So all of these efforts has seen us having to have face-to-face interactions, one-on-one interactions, indoor meetings. But with COVID, we've had to think about more innovative approaches to ensure that the work continues and the ball is not dropped. So when we think about sexual and reproductive health after the pandemic, I would say the future really depends on what we do now. And it's very encouraging, the discussion by Dr. Afolabi, who has pointed out what is being done at the national level. For us, we continue to support government and advocate for continuous commitment and leadership by all levels of government, so that they coordinate all efforts and partnerships. They support innovation, they support innovative and homegrown solutions to the challenges that we face with COVID. They also continue to strengthen family planning integration right at the primary care level so that people within the community can have access to services. NURI was able to work with the Kaduna State Primary Healthcare Development Agency during the COVID lockdown to identify and train patent medicine stores within their communities so that people could continue to access family planning services without having to leave their communities. We also encourage the civil society groups, the interfaith groups, the communities to continue to work closely with government at all levels, at the local government, state, and federal level, such that they build stronger accountability systems and monitoring mechanisms and demand for quality services. This would ensure that people who need services the most are able to get services, and that the gains that we have achieved in the last 10 years and more are not lost due to the COVID pandemic. And then finally, we also would encourage the continuous investment in demand generation and social and behavior change intervention approaches when it comes to family planning and reproductive health, so that it continues to improve the family planning discourse, it continues to address misconceptions and then change the negative perceptions around family planning, and it improves uptake of positive behaviors, which will lead to uptake of family planning services. NURI is currently working very closely with the Lagos State government to air family planning messages during this COVID pandemic so that people know that these services are available and they also know where to access those services. So I would say that the future is not yet looking dull as long as we continue to put in the effort and to prioritize family planning as an important component of what we do during this COVID pandemic. Thank you very much.
So I'll bring up our next panelist, Margaret Bolaji. So Margaret, from the youth perspective, what would you say is the impact of the COVID-19 pandemic on family planning activities? Over to you, Margaret.
Thank you very much, Precious, and good day to you, everyone listening. Of course, from SWAG Initiative, and we ensure that every girl is empowered to achieve a maximum potential, no matter where she is found. And talking about the youth perspective, next slide, please. The youth perspective on family planning activity in the wake of COVID-19. It's important to put out those facts. And is to begin by saying that young people, of course, between ages 10 to 24 constitute almost a third, that is 31.7% of Nigerian population. And what does that mean? Of course, this is from the 2006 census. However, the UN projection of Nigerian population, it's over 200 million, and that tells us that we have over 60 million young people ages 10 to 24. Of course, the proportion of unmarried young people between ages 15 to 25 that have engaged in sex within the last 12 months of when the Nigerian Demographic Health Survey 2018 was conducted. For the male, we have 35.1%, and the female counterparts, 35.1% for male, and for the females, 25.9%. Also, the proportion of young women aged 15 to 19 years that have begun childbearing is 18.7%. And lastly, the contraceptive demand amongst unmarried adolescents 15 to 19 is 16.2%. What does that tell us? There are sexual activities happening. And the truth is, despite that this was before COVID-19, COVID-19 has not stopped the sexual activities. So while also digging deep into how young people have been coping in the wake of COVID-19, we decided to ask some young people about their challenges accessing sexual and reproductive health information and services, of course, with particular reference to family planning for this particular webinar. So we're not diving into issue around rape or issue on pubertal development, child marriage, and all of that. But for family planning, this, besides just saying, because of the government restriction, I can access the facility, there is stock out, providers, and all of those things. young people these are 4 different conversation or reactions by young persons. One, it says, we have been relying on withdrawal method, aka, of course, also known as pull-out. The pull-out game has to be strong since we can't access contraceptive. Another young person says, due to the shortage of condoms, we now use salt to prevent pregnancy and it's been working. That is ridiculous. Again, another myth that was also mentioned by another young person, of course, reporting what other young people are doing in their community, says, young people around me use overdose of anti-malaria to prevent pregnancy. And the last one, it says, some of the buddies, of course, his friends around, have been coming for condoms. I can't help but get some of them from these facilities that I am familiar with. And they say, Bobo, there is lockdown. So these are just few of the different conversation that shows the challenges that young people are facing in the wake of COVID-19 pandemic. However, it is important that we ensure that youth remain a priority on sexual and reproductive health agenda. Thanks to the Federal Ministry of Health with the laudable interventions that have been laid out, have been done, are continue to do. But the one thing we must do, and it is not negotiable, is to keep engaging young people, and of course the youth-led organization and network. Why is this important? Much as we are able to get what the problem looks like from their perspective, it is also important that we bring them into the room to be able to develop the solutions together and monitor it. We need to be sure that this need or this solutions we are providing meets the need of young people. Again, it is important to strengthen engagement with private sector, especially the patent and proprietary medicine vendors, the PPMVs. So whether it is the drug shop, the chemist. Why is this important for young people? Even before COVID-19, we know a lot of young people would rather, for different reasons, it could be the waiting time, it's also the attitude of the service providers and all of that, would prefer to go to a drug shop and get condoms or any other commodities as opposed to going to the public health facilities. So it is important that we engage with these PPMVs so they can provide quality services. However, we know that they are also limited in the kind of services, especially when we're talking of the long-acting contraceptive, and that's why strengthening referral, it's a must do for us so that they can begin to refer young people to other facilities. And also when young people get to those facilities, linkages are very important. So for young people, they go to facility for different kind of services. We must be able to link all of the services together. Also, maximizing the new and traditional media to provide adequate and accurate family planning information. Again, I mentioned some of the myths and misconceptions that young people are going away with. A lot of us are on social media, and then a lot of information. We know how social media is, the good, the bad, and the terrible information gets in there. But if we maximize the new media, the social media, and ensure that young people are getting adequate information that can help them make informed decisions, informed choices, then that is really where we should be looking at in order to prioritize the sexual and reproductive health of young people, even in the midst of COVID. Again, we know how that, whether the fact that people can do face-to-face, they can read about issues on family planning, they can look up on where to go to, they can even call service providers and get counseling and know what exactly to do. So it is very important to maximize and also utilize the media. Of course, traditional media has to come in because we also have young people who are in rural communities and might not have access to internet or smartphone to be able to have to get this information. But all of this need to come together, even in a more than ever in this time. Lastly, is for sustainability. It is important that the Federal Ministry of Health and every partner, it's like all hands must be on deck to ensure that the facilities are youth friendly. It's very simple. If a facility that is youth friendly means that it can welcome young people, can retain them, and a young person can go back and say, yes, I want to come to this facility. But again, in doing all of this, what do we stand to gain as a community, as a nation? We're reducing teenage pregnancies, unsafe abortion, post-abortion complication. We're also increasing retention of young people in school. Again, that means that we're going to be improving quality of lives for young people. And lastly, we will be able to achieve demographic dividends and boost our economic gains. Thank you.
Okay, so Dr. Shittu, you're welcome.
Yeah.
Thank you very much. So how has the Breakthrough Action Nigeria project adapted family planning promotion of activities to the COVID-19 pandemic? So over to you, Dr. Shittu.
Breakthrough Action is USAID's global flagship SBC project with a presence in over 28 countries around the world. Breakthrough Action Nigeria's project goal is to increase the practice of 17 priority individual health behaviors, cutting across multiple program areas: MNCH, nutrition, family planning outreach, malaria, and tuberculosis. We have 3 intermediate results, key among of which is to improve individual and social determinants of health, addressing social normative barriers to create demand for services around these program areas. We also have results around strengthening SBC among USG partners and also strengthening public health service systems for oversight and coordination of SBC activities in the country. Breakthrough Action works in 11 states and FCT. We are currently working in 5 integrated SBC states. These are 2 states are new, that's why I've put 3+2. We work in 3 states where we implement malaria and family planning interventions, and 4 states where we implement vertical malaria SBC interventions. Next slide. So, like some of the panelists have pointed out, there are certain barriers to uptake of FP services that have arisen due to the COVID-19 outbreak. Clients are unable to access FP services due to limited movement. There's unavailability of service providers in some facilities, fear of being infected by COVID-19 because people feel that the infection is hovering around the health facilities. Community level activities that normally create demand for family planning services are no longer being carried out. And then some clients are afraid of being labeled COVID-19 patients because if there's any in the facility, people may think they're actually carriers or transmitters of COVID-19. Some clients fear they may be forcibly tested. Some people misunderstood the stay-at-home order to mean that there are no visits to the health facility. And some providers who would normally provide FP services were not always available at their posts because we're involved in COVID-19 activities. And then more recently, there's been an increase in transport costs, and this also prevents people from accessing services at the health facility. So Breakthrough Action developed a guidance on social behavior change for FP during COVID-19, and we've used that guide to modify our approaches, and I'll just take you through some of those principles of that guide and some of the ways materials we've developed around these for family planning around modified approaches for COVID-19. Like all other participants, panelists have said, we have all adjusted our work to use more virtual approaches and channels. We've modified digital and mobile approaches, using SMS, WhatsApp for monitoring, we use IVR for training of community volunteers, pushing traffic towards 321, Airtel 321 service, just so that people can get more information on family planning and gender-based violence. We've had to pre-test a lot of the new messages virtually using WhatsApp, IVR, just to ensure that the messages are appropriate for the audiences that we're trying to address. We've considered and also used community-based PAS systems like community radio, loudspeakers. Again, there are a lot of people at community level who do not have access to mobile devices that will benefit from those approaches. So one of the principles we're using is to promote equitable couples communication. Couple communication is a cross-cutting behavior for breakthrough action, where we encourage couples on joint decision making and strengthening the agency for women in the union to make decisions on their health. So we promote open and equitable communication around fertility intentions, pregnancy prevention in general, but also particularly at this time when the risk of pregnancy is higher for couples who may be staying at home for social distancing and things like that. And that's an example of a graphic that we developed with that regard. We're also increasing the feelings of self-empowerment or self-efficacy. Self-efficacy is a strong additional factor for the practice of priority health behaviors. So we're promoting the idea that clients can use methods that are they can administer themselves, like pills, condoms, emergency contraception, and Cyanapress, DMPA subcut. So they don't have to rely so much on services that may not be available because COVID-19 has been an issue. Traditionally, we would ask clients to go to the health facility to get their FP methods, but with COVID-19, we want to encourage other alternative information and service sites like the PPMVs, the pharmacies, and other community sites that are available so that clients can access their family planning methods in multiple places and places that are more easily accessible to them than the health facility. So this is a message that we actually incorporated directly into our mobile curriculum for community volunteers to spread at community level. There are reports of increased gender-based violence during this time, and again, services that normally will be available for victims of GBV may not necessarily always be present. So we're also messaging on where people can get help for if they're experiencing gender-based violence, but also messaging on how couples can address GBV within themselves, discussing their difficulties, and also reaching out to trusted people to assist with addressing issues around gender-based violence. With the COVID-19 outbreak, there's going to be a lot of messages out there in the media, on the various channels, and it's very easy to drown out messages on other priority behaviors that women and families need to practice to stay healthy. So we're also driving traffic towards other sources of information. There's the Abushirinko radio program in the northern states, where there's a drama that talks about so many priority behaviors that Breakthrough Action is working on in the various states. And there's also the Health 321 toll-free service, where our clients can get information on COVID-19, on priority behaviors, and even the Abushirinko radio program is also available on Airtel 321. I mentioned the guidance on SBC for FP at the start of my presentation. That's one resource we've leaned on heavily to guide us as we adjust our programming to the COVID-19 outbreak. We've also developed a guideline for conducting safe community engagement activities as we think through the future of our work around our priority behaviors and family planning, even with the COVID-19 outbreak. These are resources that we can share with people after the webinar, and hopefully they find them also useful to guide them as they think about how they go about their routine work, even in the context of COVID-19. I believe that's my last slide.
Yes, thank you very much, Dr. Shiku. Thank you very much for that very interesting and enlightening presentation. So we'll go on to our next panelists, and that is Adenike Ayodele. Adenike Ayodele, how has CCSI deployed social and behavioral change communication approaches to promote healthy sexual and reproductive health behaviors to safeguard the reproductive rights of women and girls? Over to you, Adenike. Thank you.
So really, CCSI has had to be creative in deploying different approaches to safeguard the reproductive rights of women and girls during this COVID-19 pandemic. First of all, we have our portfolio of projects in SRH at the moment. I mean, over the past 4 or 5 years, since 2015, has included 7 projects implemented in 17 states. And through these projects over this time period, we've been able to reach close to 4 million people. Now, what the COVID-19 pandemic did was it made us more strategic and creative, like I said, in our approaches. The first thing was falling back on our partnerships with stakeholders in government and the community. Now, the great thing about how CCSI has worked across all these projects has been that we've partnered with government and we've partnered with community structures. The COVID-19 pandemic helped us rely more on these structures. So, for instance, out of these partnerships, some of the states that had COVID-19 awareness campaigns, we were able to leverage on that platform to continue getting out messages across to people in these communities. Also, the traditional leaders, we were able to work with them, giving us town announcers in some places, even going as far as bringing traditional gongs. We also had instances where the government at the LGA level, gave us megaphones so that we could continue implementing in the communities. Now, I talked a bit about leveraging on the state COVID-19 awareness campaigns earlier on, and the trainings that I held for the community volunteers that were involved in this worked also in our favor, in that these community volunteers, because they had been trained by the state or the LGA in many levels, were able to continue mobilizing for family planning. Where we did not have the state or the LGA training the CVs, CCSI ensured that after the lockdown was lifted, when the CVs are going out, they were brought up to speed about COVID-19 preventive measures. Also, moving on from there, we ensured that all the targeted community mobilization activities were done in strict compliance with NCDC guidelines. That means ensuring that if you go for the usual door-to-door campaigns, you are maintaining a maximum of 2-meter distance between you and the people you're speaking to. The megaphones that the LGA health education officers gave us also came into play, because you then could stand at a distance and speak to people about the benefits of modern family planning methods and where to access these methods. And the thing was, the messages that were being pushed out at this period, and still on the previous slide, the messages that were still being pushed out during this period, as has been mentioned, the lockdown, it was important that we let people know that you're spending a lot of time together with your spouse at home. This is really the time to ensure that you are planning your families, or you are taking precautions. And then moving on, we also leverage on technology a lot. WhatsApp platform, phone calls, some of the projects I'd mentioned that we're working on are in the private sector. On WhatsApp, the hospital clients are on a WhatsApp group. Messages on family planning gets pushed out on these WhatsApp groups. We also had instances where, like is in that image, we had instances where the usual community dialogues took on virtual dialogue approaches. Also, still talking about leveraging on technology, the slide up here shows the DMPA how to self-inject instructional video. This was another way of reminding people that, other panelists have talked about self-care. There's this method available, and you can actually self-inject yourself. And we know of projects where this video was actually also used to train providers and PPMVs so that they could give this to clients who were taking up this method during the pandemic period. Margaret talked about leveraging on traditional and new media, and that's something that we also did during this period of the pandemic. The first one, on the Rashidin Project, there's a radio program that's airing in 9 states. This radio program features experts in FP, and people are able to phone in and have their questions answered. Now, we're driving traffic through individuals, the individual community volunteers who could speak to their neighbors in their communities, and also online, letting people know that this program is happening and you can phone in with your questions. And in a period of 2 months, across those states, we had almost 120 phone calls. Still looking at new media now. We also use Twitter. We have an ongoing partnership with the popular Aproko doctor on Twitter, and he's been able to take the message of FP use of contraception among young people to really get that message across in the way that resonates with young people online. And there's been so many interesting conversations. I'd encourage you to check out his handle and CCSI handle on Twitter as well to see some of the interactions we've had in this period. On new media too, we've tried to expand those conversations that's happening on Twitter, expanding it to Facebook, sharing those messages on Facebook as well, and taking some of the content we're using on the radio program to the Facebook audience. Now, as has been mentioned, working on using all these approaches has not been without challenges. And I know right from Dr. Afolabi's presentation to Dr. Shitu's own, we've seen the low turnout of clients, and a big thing has been the fear of contracting the virus. If I go to the health facility, will I be able, is that not exposing myself? So, aside from also reinforcing the need to take preventive measures, make sure you're washing your hand, make sure you're wearing face masks when you go to the facilities. We also leveraged on the presence of community providers. Dr. Shitu talked earlier about the PPMBs on Rasudin. There are community resource persons who are able to provide services. So there were instances where the volunteers were actually referring to those community resource persons so people could take up methods immediately. And then the fact that, you agree with me that not everybody is on new media, we still have these remote communities, and the activities where we could really do, like the going from door to door to speak to people, a lot of these had to be dropped during the lockdown period, for instance. And even now that things are gradually being lifted up, we still have to be very careful in how we're engaging with people in the community to make sure that both the community members and the volunteers that we work with are protected. And we're optimistic that with everything the government is doing, plus our partnerships with them, we would see more people coming out to take up methods, through all these diverse approaches. And thank you very much, everyone, for listening. Over to you, Precious.
We'll now go over to the Q&A. We have quite a number of questions. We have a lot of questions, and we are looking at the time, but we will try and ensure we answer a number of the questions. So over to the panelists now. Panelists, please, can you have your videos all on? The first question to Dr. Afolabi. We have a number of questions here. So Dr. Afolabi, quite a number of concerns about the charges that we get in our facilities. So how is the Federal Ministry of Health working towards ensuring that this will not affect the uptake of family planning in this present time? Yes, we say family planning is free, but you find people go to the facilities and they are charged as much as 3,000 Naira for an FP method. So this question is over to you, sir, and we would love to hear your response, and the floor is open.
Issue of service providers charging under the table fee is really a challenge that we have recognized, and we are addressing jointly with the state government, because we need the buy-in of the state as well as buy-in of service providers to ensure that the free policy of federal government on family planning, information, commodity, and services succeed. Thank you.
So Dr. Saratu, the NURI strategies that we have in place to ensure that there's service provision by PPMBs, was it captured in the state DHIS? Do you want to throw in a bit more light on that?
Okay, so thank you for that question. So NURI strategy generally is to support this government to achieve its family planning mandate and to ensure family planning programming. So we don't create parallel systems outside the government, but we work very closely with government, providing technical assistance to ensure that services are being provided. Now, the support that we gave in Kaduna State was done hand in hand with the State Primary Healthcare Development Agency. So the planning, the implementation was done with the Primary Healthcare Development Agency, and NURI provided the additional technical support that was needed to ensure that family planning programming was included in the work that they did. Now, during the COVID, the Primary Healthcare Development Agency spent a lot of time training patent medicine stores and patent medicine providers to ensure that services are available within communities, since there was a restriction of movement. What NURI brought to the table was to make sure that family planning was also one of the key messages that was integrated into that training. So the trainings were conducted in each local government. They did it one local government after the other. They used a combination of both virtual systems and, should I say, semi-virtual systems. They got multiple halls within an LGA, usually about 3 or 4 at a time, where they could have about 10 participants that observed social distancing, and they would train them, and this would run for multiple days. So NURI supported all of that effort by making sure that family planning services and family planning information was a key part of the training that was provided. Patent medicine vendors normally provide non-prescriptive methods, but with the support of the Primary Healthcare Development Agency, we were able to include the DMPA subcute so that community members could have access to that method during the lockdown, and then to also link the patent medicine stores with the primary healthcare facilities within the host communities. So all of the work was done with the Primary Healthcare Agency. This in itself ensured that reporting went back to the primary healthcare facilities and would enter the HIS. So in summary, that's the kind of work that we do in NURI to ensure that government is doing what it's supposed to be doing. And that way, we get to provide a lot more services and expand the reach to ensure that people are actually getting the quality services that they need, even within their community. Okay. Thank you.
Thank you very much, Dr. Saratu. Thank you for throwing more light on how we have actually engaged PPMVs. Margaret, we have a question for you. So around the youths, is there a call center that exists? Could that be an option to reach out to some of these young people, even in the climate and in the situation that we have currently found ourselves in during this COVID pandemic?
Thank you very much, Precious, and thanks for the question. There are several call centers, and I have to first mention that of NURI 2, which is 321, where people can call and speak to a service provider. Interestingly with that is the fact that the service providers have been also trained to offer youth-friendly services. So when in the matter of ensuring confidentiality, also making sure that you're not biased when providing balanced counseling, all of that has been taken care of. There are other organizations like AVA who also have some other numbers that you can call. So, however, it is important to know that the government needs to be on top of this. So, because again, depending on the state, intervention state, programs have had to have those numbers in different states. But again, because it's important to reach out to every adolescent, regardless of where they are, whether they're in the rural community or they're in urban community, whether they're living with disability or not, we need to scale up this kind of call center to ensure that every young person knows what number to call, and when they call, they're able to get those services.
Awesome. Thank you very much, Margaret, for that response. Dr. Shitu, we have a question for you. So prior to COVID-19, were the FP commodities free? And if they were free, currently will out-of-pocket purchases not limit the usage of the FP commodities? That's a question we just want you to speak to. Over to you, sir.
Thank you, Precious. I think Dr. Afolabi has touched on that question already. FP commodities are free in government health facilities. The costs that people tend to have incurred in the past were usually costs for consumables. But consumables are increasingly being provided now by the federal government and also by the state governments in the various states. And Dr. Afolabi has already mentioned how steps will be taken to ensure that those sharp practices of charging for consumables are addressed. So for all intents and purposes, the only additional cost a client may incur is just the cost of getting to the facility to get the service. But beyond that, the commodities should be free, the consumables should be free. It's not always free everywhere, but it's something that is being looked into by the various by government at various levels.
Thank you very much, sir. Thank you for reinforcing quite a lot of insights that came also from Dr. Afolabi. Adenike, so we want you to throw a bit more light on the DMPA-SC, the self-injection, the administered contraceptive. Could you throw a bit more information and give some more insights into that method that you actually spoke about during your presentation?
Okay, thank you, Precious. So the DMPA-SC, I think Dr. Shitu and a few other people had mentioned it, is one of the methods that the government is currently rolling out in Nigeria and has the option for self-injection. I will put the link to that. There's a video and that was a clip that I had on that slide. There's a video that guides clients through how to self-inject. So CCSI supported through the Rasudin project, worked with government to adapt that video for the Nigerian audience using live models. And this video has been rolled out. You can get it from government and you can get it online as well. Like I said, we'll share the link. It's a method that a provider, it's similar to the injectable method, but this one it comes in a pre-filled device and the client has the option to self-inject. But a provider takes them through how to self-inject first before the client starts self-injecting. I'll stop there, but like I said, we'll put the link to the video and connect people that want more information on that blog post. Thank you.
Thank you very much, Nike. And on that note, we would like to say thank you very much to our panelists and thank you very much to the audience. And I'll now hand over to the Executive Director, Center for Communication and Social Impact, as she takes on the floor. Thank you.
Thank you very much, Precious. And thank you very much to our able, distinguished panelists. I don't even know how to say thank you to all the attendees that we have online. It has really been awesome. Thank you for taking the time. Everybody is busy, and in this era of COVID, everything is now online. And to actually block your diaries, your calendar for more than an hour, we really do appreciate that. I am really pleased at the kind of interactions and the conversations that are going on. It's just such a shame that we can't take all the questions, but as the moderator has said, we will try and answer all these questions and put them online so that you can find the answers to some of the questions you have and then also see how we can push these conversations forward. I, however, want to summarize. I found one of the quotes dropped by one of the attendees, very interesting, which summarizes where we are in this era of COVID. Let me go back first before I say that to some of the experiences you dropped about how the first 6 months have been. Somebody said tiring, some people said frustrating, some said interesting, some said exciting. I don't know where the excitement is from. Someone said strange. And yeah, but I think a lot of us said it's been interesting. And let me go to that quote as I round up. And someone said, the silver lining of the COVID era is the opportunity for homegrown innovation. So let's bring all our ideas home. Let's bring all our creativity together. Let's see how we can push the box. Which box? Let's see how we can throw the box away so that we can actually do things even much better than we have been doing them. So on that note, I just want to end by saying thank you. We are over by 15 minutes, but it's 15 extra minutes very well spent. Thank you very much, our panelists, and thank you so much to the attendees, without whom we would not have been able to hold this webinar. Thank you very much, and God bless. Bye.
Thank you very much, sir. Thank you for reinforcing quite a lot of insights that came also from Dr. Afolabi. Adenike, so we want you to throw a bit more light on the DMPA-SC, the self-injection, the administered contraceptive. Could you throw a bit more information and give some more insights into that method that you actually spoke about during your presentation?
Okay, thank you, Precious. So the DMPA-SC, I think Dr. Shitu and a few other people had mentioned it, is one of the methods that the government is currently rolling out in Nigeria and has the option for self-injection. I will put the link to that. There's a video and that was a clip that I had on that slide. There's a video that guides clients through how to self-inject. So CCSI supported through the Rasudin project, worked with government to adapt that video for the Nigerian audience using live models. And this video has been rolled out. You can get it from government and you can get it online as well. Like I said, we'll share the link. It's a method that a provider, it's similar to the injectable method, but this one it comes in a pre-filled device and the client has the option to self-inject. But a provider takes them through how to self-inject first before the client starts self-injecting. I'll stop there, but like I said, we'll put the link to the video and connect people that want more information on that blog post. Thank you.
Thank you very much, Nike. And on that note, we would like to say thank you very much to our panelists and thank you very much to the audience. And I'll now hand over to the Executive Director, Center for Communication and Social Impact, as she takes on the floor. Thank you.
Thank you very much, Precious. And thank you very much to our able, distinguished panelists. I don't even know how to say thank you to all the attendees that we have online. It has really been awesome. Thank you for taking the time. Everybody is busy, and in this era of COVID, everything is now online. And to actually block your diaries, your calendar for more than an hour, we really do appreciate that. I am really pleased at the kind of interactions and the conversations that are going on. It's just such a shame that we can't take all the questions, but as the moderator has said, we will try and answer all these questions and put them online so that you can find the answers to some of the questions you have and then also see how we can push these conversations forward. I, however, want to summarize. I found one of the quotes dropped by one of the attendees, very interesting, which summarizes where we are in this era of COVID. Let me go back first before I say that. So some of the experiences you dropped about how the first 6 months have been. Somebody said tiring, some people said frustrating, some said interesting, some said exciting. I don't know where the excitement is from. Someone said strange. And yeah, but I think a lot of us said it's been interesting. And let me go to that quote as I round up. And someone said, the silver lining of the COVID era is the opportunity for homegrown innovations. So let's bring all our ideas home. Let's bring all our creativity together. Let's see how we can push the box. Which box? Let's see how we can throw the box away so that we can actually do things even much better than we have been doing them. So on that note, I just want to end by saying thank you. We are over by 15 minutes, but it's 15 extra minutes very well spent. Thank you very much, our panelists, and thank you so much to the attendees, without whom we would not have been able to hold this webinar. Thank you very much, and God bless. Bye.